Kate. And now I have one of the best jobs there is in the state because I get to work with incredible colleagues both at the law school and the Institute. And our leadership team at the Institute, I see Jean Ryder with the Citizens Health Initiative and our Institute up here. And Laura Davey is here as well. Hi, Laura. And Amy Costello is somewhere in our world tweeting and messaging us. And Joe Porter, just a phenomenal colleague to work with on all issues. Her knowledge of data and her knowledge of policy inspires us every day. And she is the director of our institute and going to be kicking off the content portion of our program today. So thank you, Joe.
Thank you, Lucy. Thank you. And thank you all for coming. I really appreciate this. You know, I was saying to somebody last night, Lucy and I, when we started talking about this with others, weren't real sure how many folks we'd get in a room to talk about Medicaid, right? And then some stuff happened in Washington, and all of a sudden this became even more pertinent than we ever could have imagined. So thank you all for taking the time to be with us today. I'm going to queue up some slides, but as I do that, there is an activity we would like you all to take on. In your packets, there is a couple of index cards. Our packets were so full, you can see you didn't actually have all your slides in the pockets. But in a pocket, you will find an index card. And what we'd like you to do is take a second while I queue up the slides and answer for yourself this question that's up here, which is, what are you most interested in knowing about the Medicaid population? And our hope is over the course of the next content sessions, the one that Deb will give in a minute and one that I will give after the break, we will hopefully answer some of those big questions that you have about the Medicaid population. But in the event we don't, we would like you to have your questions ready. So when we get to the Q&A period, you can ask some of those questions to our panelists and our speakers. So take a second, think about what question you have that is the most pertinent and the most pressing about the Medicaid population, and then we will revisit this in a second. All right. So, as you think about that, it is my distinct pleasure to welcome Deb Fournier. Deb Fournier is the Medicaid Director for the state of New Hampshire. She was appointed to that position after serving as Deputy Medicaid Director and Senior Health Policy Specialist in the Department of Health and Human Services, as well as in a number of positions within the New Hampshire Fiscal Policy Institute and other kind of key areas in New Hampshire that gave her a really good background for how to take over a program that is in as much change, potentially, as it is now. Deb's bio is in your packet. I won't read the entire thing, and I want to make sure we give her as much time as possible. I'm also going to note that we are ahead of schedule. That might be the only time that happens today, so I think it's worth noting. But I want to cede the floor to Deb, who is going to talk to us about the New Hampshire Medicaid program and really level set with all of us about the complexity of the program, which I think folks don't always understand. Hi. Oh, sure. Come on in. No worries. Welcome. The good part's just about to start, so you came just in time. So please welcome Deb Fournier, Medicaid Director, to the podium.
Good morning. It's so nice to see so many people interested in Medicaid. Usually it's just Joe and I geeking out on the phone together about Medicaid. So I'm Deb Fournier. I am, in fact, guilty as charged, the Medicaid Director for the state of New Hampshire. I heard a few things this morning that I wanted to comment on. One was that I grew up looking at Mount Rainier. If you go out there, people in the area just call it the mountain. And she peaks in and out, right? Because it's often very cloudy, as one would imagine. But it is a beautiful place, and I hope you go. The other thing is that Yvonne said, it's an interesting time in health policy, and I really wish it would stop being quite so interesting. So this is my Medicaid 101, and it's just to level set so that we're all starting from the same shared understanding of what is Medicaid and what is, in particular, New Hampshire Medicaid. Joe, if I just use the button, oh, look at that. So, Medicaid is a publicly funded health insurance program for poor people, right? And in any given day, it serves roughly 187,000 people, including the expansion population. 187,000 people who live in the state of New Hampshire. And in very broad strokes, and I feel like I'm sort of doing oral finals in front of my professor because I'm explaining Medicaid in front of Cindy Mann. It works like this. Medicaid is elective. Not all states don't have to have a Medicaid program, and currently all states in the nation have elected to have a Medicaid program. But if you participate, there are certain ground rules. You have to cover certain mandatory populations, and you have to give them certain mandatory services. And there are slides later, and we'll talk about what those are. And then, according to a state's own budget or policy priorities, there are optional populations and optional services that it can choose to also cover. In exchange for following that basic framework, probably the most dynamic thing about Medicaid is that the federal government always pays a fixed percentage of the cost. So the lowest percentage is 50. And New Hampshire, because of its relative wealth, it's called FMAP, the Federal Medicaid Assistance Percentage. It's based on per capita wealth. New Hampshire is a relatively wealthy state, so we have the lowest. As our baseline for certain services or for certain people, certain populations, you can get a higher FMAP. Women with breast and cervical cancer get a more favorable FMAP. Adults in the expansion population, to entice states to move along with taking on the expansion, have a very favorable FMAP to states. And that allows a certain amount of financial security for any state, because if there's an AIDS crisis and 10,000 people who are working age become too sick to work and their incomes fall, a Medicaid program could expand and still receive financial participation for their coverage. Or if there, as in more recent years, there's a great economic downturn and children's parents are thrown out of work and the insurance that was covering the family has evaporated, those children can be covered. And that fixed financial participation from the federal government is always there. So it is my main goal as the Medicaid director to make sure I say this to everyone that I see publicly. Medicaid, pound for pound, is a kids program. I cover, aside from the expansion population, which is about 53,000 people, adults, we cover 90,000 kids under the age of 18. And maybe 2,000 of those kids are the kids who have pretty profound disabilities. So most of these kids are very typical kids. We also cover low-income moms or women who are expecting. People with disabilities, this is the other huge component of Medicaid. It is the dominant provider of long-term care services, including home and community-based care for elders and people living with disabilities. We cover some very, very, very low-income seniors. And then the low-income adults in this slide are really parent caretakers, folks still associated with welfare programs, TANF. I should make a note. When Medicaid was born, it was tied to cash assistance programs. And so over the years, it has slowly separated itself from that and has been able to cover people beyond the eligibility groups for what is now called TANF, Temporary Assistance to Needy Families. So this slide doesn't cover the expansion population, which I should also explain. When expansion was enacted in New Hampshire, the funding for it is put through a trust fund that essentially isn't in the budgets for the state of New Hampshire. And so New Hampshire Medicaid has sort of built up its reporting systems to have what it calls standard Medicaid, which is everybody that was in Medicaid before expansion, and then expansion off to the side because it's sort of run off. It isn't run off budget, but that's the way we've developed it for reporting purposes. Okay. So the mandatory services are the top grid, right? That's what you have to provide. If you choose to provide Medicaid in your state, you have to provide these services. Now remember, this statute was created in 1960, or enacted in 1965, right? So from a 2017 perspective, what is fascinating is that the optional services, the top two, are prescribed drugs and mental health services, which we can't imagine not covering right now as part of any health insurance program. But they were optional because prescribed drugs hardly held the position that they currently do in the practice of medicine now, back in 1965 when it was created. And then our home and community-based care waivers are technically optional, but we choose to sort of segregate them at the bottom just so that folks don't think, don't forget about them really, because they are very, very important. So the cost of our optional services, as you can see for our kids and our adults, runs at a pretty good clip. And as I mentioned, the home and community-based care, prescription drugs, and our community mental health service center services are our top line items in those optional Medicaid service categories. So these are our mandatory eligibility groups. We cannot operate a Medicaid program unless we cover these folks, right? So parent, caretaker, infants and children, pregnant women, low-income moms and kids, very low-income people with disabilities, very low-income people who are seniors, and then we do have some very special refugee coverage, foster children coverage, and folks who are low-income Medicare beneficiaries. Medicaid can step in for the Medicare beneficiary and help to defray the cost of premiums and cost sharing for them, which is a huge benefit to those people, so they can manage their Medicare coverage. And these are our optional eligibility groups. You'll notice that the first two are the same as on the prior slide. It's just that their income eligibility goes up. So we have to, in other words, we have to cover parent, caretaker, infants and kids and pregnant women essentially up to 133% of the federal poverty level in order to have a compliant Medicaid program. Whoops. But then New Hampshire has elected to cover them at income ranges even higher than what is required in order to provide coverage to those groups of people. And at the very bottom, in New Hampshire, NHHPP is what the name is for our expansion eligibility group, New Hampshire Health Protection Program. I'm gonna, Joe, do we do questions in the middle? Sure. Everybody okay? Yeah. Yes.
The Katie Beckett children. Sorry, I'm not familiar with that.
So Katie Beckett kids are kids with disabilities, yeah, who have a certain profile and a certain income range, yeah. Anybody else? Yes, Michelle.
What is the percentage? We have 90,000 kids on Medicaid who are captured by the expanded income bracket.
Oh, low-income kids?
Yeah.
Oh, I want to say that's that most of the kids are in the initial group. Whoops, I keep going back. Oh, actually, we can look at the next slide. Yes. Oh, so Michelle said, how many kids are in the low-income children group, and how many of the 90,000 kids are in the 134 to 185? Yep. So it's about 14,000 kids who are between 134% of the federal poverty level and 300% of the federal poverty level. In other words, the vast majority are deeply, deeply poor because their incomes are essentially equivalent with the expansion population. So the case loads in New Hampshire, this is just over the last 9 months or so. Well, the last year, actually. And we have had we have seen a decrease overall in the standard Medicaid enrollment of about 2% over the last year. We keep gaining the kids in the low-income children's population, the kids from 134 to 300. But we are slowly shedding pregnant women and some people with disabilities, and our suspicion is that they have fallen into the health protection program because you don't have to wait to qualify for those. You don't have to be pregnant, and you don't have to have 48 consecutive months of disability to qualify. If you are income eligible, you are eligible. Our expansion population, we're right at 53,000. We can't seem to break 54. So I think that we've hit a plateau. But again, pound for pound, 90,000 kids, most of whom are just poor. They don't have any other special profile about them. And then this is another way to think about it. So again, in New Hampshire Medicaid, the way we think of the populations institutionally, and by that I mean within the department, is that we think of standard Medicaid as being all of the folks above, in this, leading up to the standard Medicaid line here. And then the expansion folks are here, right? So that looks, I can't figure out the buttons. That looks here that standard Medicaid is the blue line and expansion is the green line. Are there any questions about that? So if you put the two together, we cover just over 13% of the state's population. About right? Yep. And again, because I can't get off the kids are the vast majority of my standard, non-expansion, Medicaid managed care participants. But, oh, yes, Dr. Harker.
So, Deb, I'm wondering, so that's the distribution of patients in Medicaid. So I'm wondering if you have a similar graph that talks about the spend per category.
Well, let's go to my very next slide.
Can I just make a quick announcement? If you ask a question, see these things hanging down? Those are the mics. So it's weird, I know, but we appreciate if you kind of talk to the sky. Ask that question so that the folks who are on the web can hear you too.
Yeah. So what Dr. Harker asked was, okay, that's your enrollment, but what's your spend by those same categories? So again, this is inside of Medicaid managed care. So my costs are concentrated among the elderly and the people with disabilities. That is not unique to Medicaid. That is true in any delivery system, right? There are a few folks who are very complicated and complex, and they are expensive. And so you can see it here between the adult disabled folks who are elderly and live with disabilities, and the children using long-term care services or the kids using DCYF services, right, are the minority of my population in Medicaid, but the majority of my spend. Or to think about it another way and to underscore the other main component of Medicaid that makes it a unique payer is, as I said, Medicaid is the dominant payer of long-term care services in the nation. Medicare pays for short-term medical services for some folks with disabilities and retirees, but it has no long-standing long-term care service. It pays for 100 days of skilled nursing facility care. Medicaid pays for ongoing skilled nursing facility care and home and community-based services. So expressed another way is that long-term care services are the single largest proportion of the spend in Medicaid. It's not quite a majority, but it's close. Because if you look at, I have 4 1915C waivers. We'll talk about those in a minute. Those are home and community-based care waivers. So the nursing home is 20%, almost 20%. CFI is Choices for Independence waiver. That's a 1915C waiver for folks who are elderly or with disabilities who would be eligible for a nursing home level of care, but they want to remain in the community or at home. And then my other 3 waivers, or it says other waiver, are my acquired brain disorder waiver, the developmental disability waiver, and the in-home supports waiver for kids with disabilities. So together, it's 47% of my spend. And unless folks are very well off, they cannot purchase those services, right? They're not available on the marketplace. They're not really attached to any other health insurance program, commercial or otherwise. They are a standalone type of policy. And whenever I have heard them discussed, I've heard them discussed in a component of an estate law or a financial planning seminar that says, tell your clients that if they want to leave something for their kids, they need to buy some long-term care insurance, because otherwise they're going to have to divest themselves of their assets to receive Medicaid coverage. Linda.
Given the potential aging in New Hampshire of our population, do we have any projections on what the impact might be on Medicaid?
Steve Norton. Have You have done a lot of work on that. I don't have that in my slide, but I'm sure Steve has done something, I think,
Glad to
several
share
years
it.
ago,
Yes,
yeah.
a couple years ago.
Yeah.
Glad to share the report and you can distribute it.
Yeah, yeah. So that's who we cover and what we cover, right? Which people and which services. So this part of the discussion is how we deliver the services. And I call them delivery systems. We have 3 different mechanisms for delivering the benefits to our folks. The first is Medicaid managed care. The second is premium assistance and the New Hampshire Health Protection Program. And then last is fee for service. And these are really descriptions of both how we pay for the service and who administers them. I'm going to come back to that one. I want to describe the system first. So Medicaid managed care is the delivery system for standard Medicaid for the bulk of my enrollees. So we have contracts with 2 health plans who are both graciously here today, New Hampshire Healthy Families and WellSense Health Plan. And we have full risk capitated style arrangements with them. That means that the state pays a per member per month rate to each health plan for each enrollee enrolled with them every month. And again, we have just about 133,000 people in that delivery system. So those 2 health plans administer all of our short-term medical services that were back on that slide of the mandatory and optional services, but for skilled nursing facility care and the home and community-based services. So premium assistance is our hybrid public-private Medicaid expansion. So the way it works, in short, is this. We received permission from the federal government to use the Medicaid funds attributable to the expansion population and use those funds to purchase qualified health plans, which are commercial health products certified for sale on the individual federally facilitated marketplace in New Hampshire. They're called QHPs. So in other words, we're using Medicaid dollars to purchase commercial coverage. The program has been operational for over a year now in that model. The expansion folks were covered by our 2 managed care companies while the state was negotiating with the federal government about how to get permission to use the Medicaid funds in that way. So we have 4 commercial carriers: Anthem, Harvard Pilgrim, Minuteman, and Ambetter, which is Healthy Families' commercial counterpart. And even though there are 53,000 people in that eligibility group, 42,000 of them are actually served by the commercial carriers. And the commercial carriers give them the bulk of the benefits, but because they are technically Medicaid enrollees, they are entitled to an additional litany of services that aren't offered through the essential health benefits, which are what is required for qualified health plans to offer in order for them to be certified for sale on the marketplace. And so they're called WRAP benefits, and those are standard Medicaid fare, non-emergency medical transportation, free choice of provider for reproductive health and services, and we have a limited dental and limited vision benefit for adults that the qualified health plans aren't required to offer. And so New Hampshire pays fee for service to give beneficiaries those benefits. One of the features of the premium assistance demonstration, you get this long packet, it's called the STCs, the Special Terms and Conditions, when you finally reach agreement with CMS. And the STCs require that if someone identifies themselves as medically frail, that they cannot participate in the demonstration. And that's really a nod towards the richness of the benefit that Medicaid offers, and that there might be components of a service offered in Medicaid, like functional support services or targeted case management, especially for our community mental health clients, that while they would receive mental health services in the qualified health plan, those extra sort of richer benefits would not be available to them. And if they need those, they can put up their hand and say, I'm medically frail, I want to return to Medicaid. And then they can access those services there. At the time that it was enacted, or it was approved, the demonstration, we had no substance use disorder benefit for the folks that were typically in managed care. So the other component of this was that we had to have the substance use disorder benefit available to people on the Medicaid managed care side if they said, well, I'm medically frail, but I still need that benefit. And if they needed long-term care services, they could get the traditional Medicaid benefit. So about 6,000 folks are medically frail and don't participate in the premium assistance demo. And then there's another 3,000 that are, in any given month are in their selection window. They come in, they come out, they're choosing a qualified health plan or an MCO. And so this was our April enrollment. But what I want to point out to you is that there is a tremendous amount of churn for people. Only 30%, not even, just shy of 30%, have been covered by this eligibility group for all 24 months. So Joe asked earlier, what is your Medicaid question? Something that I would like to know is what happens to the other 70% of the folks in those intervening months? And is it employment related that they come in and come out? Is it changes to the family construct that bumps them out of eligibility? You know, what happens? What my own records can tell me is that the top documented reason why clients disenroll is that they're over income, right? So they've picked up a third shift, or they've received a better job, right? Those are good problems for them to have. But that did not provide means they didn't submit all of the required information to re-up. And other is an institutional issue we need to figure out, which is what exactly goes into that category and what are we missing there. But I want to know, right, what is happening in those intervening months. One of the great successes that Senator Bradley was referring to, I believe, about the New Hampshire Health Protection Program is that it has been a mainstay for confronting our addiction issues and our opioid crisis in particular, because it has been one of the main ways that we've been able to start right away offering people access to substance use disorder treatment who had never had it. So, you know, like I said before, we seem to be at a plateau with our enrollment. We can't seem to bust beyond 53,000. Every year around open enrollment, we get a bump because people are, you know, whacking the bushes, reminding people to get enrolled while it's open enrollment on the federal marketplace. But we tend to see that subside. And then, so that's our second, right? So we've covered Medicaid managed care, 2 full risk capitated staff. Yes, sir.
That approach that New Hampshire took of the public funds for buying private insurance,
Yeah.
is that fairly rare nationally?
Yeah, there's 2 other states, Arkansas and Iowa, that pursued it. Arkansas's program is very robust and continues. Iowa lost too many carriers from its marketplace and actually couldn't continue it and had to modify it. I would say we've been very fortunate. Our commercial partners have been excellent partners, and the program runs right along. But yeah, it's only 2 other states currently. Okay, so Medicaid managed care, premium assistance, fee-for-service. So this is our legacy reimbursement system, fee-for-service. It's what most medicine is reimbursed through today. So I go skiing, I'm a terrible skier, I fall down, I break my shoulder, I go see Dr. Harker. I go to his office, the people help me into the room, they say, oh, what's the matter, my arm really hurts, we get an x-ray, they look at the x-ray, then they'd say, well, we would put a cast on. So those are all billable events, fee for service, right? So our entire Medicaid population was served that, was their providers who served them were paid through fee for service until 2013. When the Medicaid managed care system went live in New Hampshire Medicaid. So we still have fee-for-service because we still have people who are permanently outside of the Medicaid managed care system because it was hard to figure out how to configure them into a benefit. So that's people who are spend down, you know, where they have to spend down their income every month into a certain income category because of their medical bills in order to qualify for Medicaid. Folks with VA benefits. There's somebody else I'm not remembering. Oh, and our family planning folks. Thanks, Commissioner. See, still remembers. We do that. We do dental. A required benefit for children is dental. It's not required for adults, and our entire dental system is still paid fee for service. Our long-term care services, our skilled nursing facility care, and all 4 of our waivers, our 1915C waivers, are still, the reimbursement to providers still occurs through a fee-for-service system. Oh, I wrote it right there. You were just reading my slide. It says family planning right there. So those are our delivery systems, right? Managed care, premium assistance, fee-for-service. New Hampshire Medicaid also has actually 7 Medicaid waivers. So the principle of a waiver is that you ask the federal government to waive certain requirements of the federal Medicaid law, and that you make a deal with them that says how we're going to do it still meets the ultimate purpose and goal of Medicaid, but we have some unique circumstances in our state, or we have some unique priorities, and so we want to do it this way. Can we please do it that way? So we have a 1915B, which allowed us to mandate enrollment into managed care for folks who were in several protected categories under federal law that couldn't be mandated aside from that waiver authority to enroll in a managed care system. We have 4 1915C waivers, right, that allow us to really concentrate provision of home and community-based services for very specific groups of folks. And that's, again, our DD waiver, our developmentally disabled waiver, our acquired brain disorder waiver, our in-home supports, and choices for independence. Medicaid, like every other health insurance program, loves its acronyms. So you will typically hear those referred to as the DD waiver, the ABD waiver, the IHS waiver, and the CFI waiver. And then we have 2 1115 waivers. The 1115 waiver is the mechanism through which we have been allowed to pursue the premium assistance construct, where we were allowed to use our Medicaid funds to purchase the qualified health plans for folks. And then our most recent addition to the family is our building capacity for transformation DSRIP waiver. We all good? Everybody still awake? So exciting, Medicaid policy. I know you're really excited. So DSRIP stands for, did I spell it out? Delivery System Reform Incentive Payment Program. So the DSRIP is meant to give us a way, to give the state a way to attack our 3 major issues with our behavioral health capacity in Medicaid in New Hampshire. And so for everybody who has not been thinking in detail about health policy around behavioral health care, I think actually everybody in this room has been, but so those big challenges for us were we don't have enough people on the ground to provide behavioral health services to our people. These are hard jobs, these are burnout jobs, they are heartbreak jobs, and we just don't have enough folks. So we wanted to take some steps to get some more folks on the ground, right? We also have 2 systems that don't talk to each other. We have a physical healthcare system and a behavioral healthcare system. And Jay, I'm going to use my anecdote I always use. And they go like this. They don't talk to each other, right? So let's say that Jay's center does a great job of servicing a schizophrenic patient, and he's been going there for 10 years because he knows everybody, and he knows they have a system for helping him stay compliant, and so he goes there. But because of his mental health issue, he has some physical health care issues that are exacerbated. But Jay doesn't have folks necessarily on hand who can look at his cardiac care or his respiratory needs, right? On the other hand, there's a statistic that's probably 15 years old now nationally that says that almost 50% of people who die by suicide are seen in their primary care office within 30 days of their death, right? So that's a big number, right? And it's, right, everybody's sort of stunned, right? So they don't talk to each other. We don't look at all facets of everybody in all of these settings. And that's not New Hampshire Medicaid laying blame at anyone's feet. It's the way the system has grown up. And again, if you don't have enough capacity to deliver health care, and Jay, right? This is a thin workforce, constantly struggling to keep up with the demand, and the demand is great. like, how can she also find additional people to provide those other necessary services, or ask her providers to also become primary care providers while they're busy also being behavioral health care providers, right? So that was the other thing. We're trying to get the two systems to integrate, to talk to each other. And the main way that we wanted to focus on that was to require that no matter where someone shows up in the system, whether they only show up at Jay's center because that's where they feel the most comfortable, or if they only go to their primary care office because they're too afraid or too ashamed or whatever, or too busy to get care anyplace else, that the person is assessed for all of the domains of their health care, including their mental health and addiction profiles. And then the third one was gaps and transitions of care, right? We have people who leave vast institutions, correctional facilities, New Hampshire Hospital, and we know that the rates of their follow-up care in the last decade have fallen, and that lack of follow-up care, especially in a correctional context, means that they will most likely re-enter that facility. We were told by corrections that they estimate that 48% of the people, who get their probation revoked or violated do so because of an underlying and unaddressed behavioral health care issue, right? So how do we get at those issues? And this was a way that we did it, was through the district. So we essentially asked providers to organize themselves with their competitors into 7 regional networks called integrated delivery networks, and they had to be full spectrum. All of the typical medical providers, behavioral health providers, multiple community-based organizations, nursing home, county nursing homes, and or county correctional facilities had to be in every single one of the networks. And then that was, January to April. Hurry up, guys, and go organize yourselves. Tell us if you want to be an IDN by May. We're going to tell you if we're going to approve you as an IDN. Did you hit all those standards that we wanted you to hit with respect to who's in your network? Then they had to tell us what they were going to do as an IDN relative to some measures that were associated with the project. And then we had to tell them whether or not we approved those project plans moving forward. Here's the other way to look at that. So 2016 was the first year of the demo. It was a very, very compressed year. But we made it all the way through. And in the process, in 2016, we distributed $19.5 million to each of the 7 IDNs to help them with their project planning and project implementation. And then in January, we awarded another $5.5 million to the IDNs. So they have now been working, January to present day, to finalize their implementation plans about how they are going to start addressing those 3 big topics: integration, capacity, and transitions. They were required to participate at a statewide level on workforce issues and health information technology issues, because those are fundamental to all of them, and there might be some economies of scale if they all work together on those issues. And then they were required to build 3 community-driven projects. So 3 projects that they had to do a community needs assessment of their region, and then say, okay, our assessment says this, which of the projects that are offered reflect avenues for us to address that issue in our region. And they also have one main core competency project, which is the big integration project. They all have to do it, but they all drive it at the IDN specific level. So I'm not going to read these. You guys can look at those. But I had a lawmaker say to me, seems like an awful lot of meetings for an awful lot of money. And I said, well, Senator, if you're going to do things differently, you actually have to plan to do it differently. You can't just wake up one morning and say, oh, today we're going to deliver medicine in an integrated, efficient way and completely differently than we did it for the last 30 years. One of my favorite things about the district and how it's really relevant to what's we're all going to discuss later today is that this is a performance-based program. So we gave seed money in the first year. We gave those $19.5 million and the $5.5 million. And now we are in the second year where the IDNs earn their dollars. They earn incentive payments for hitting metrics affiliated with the projects. So in the first few years, most of the measures are process measures. Did you build an advisory board? Did you go to all of the statewide HIT task force meetings? Did you get a governing body? Did you get a data governing body? Did you get a clinical governing body? Right? Yes, 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 yes. And that shifts over to performance. So that by years 4 and 5, there are select quality measures tied to one or more projects. All of the measures are tied to the big core competency project. And if they hit their measures, they earn an incentive payment. If they don't hit their measures, if they hit none, I should say that differently. If they hit none of their measures, they get none of the incentive payment for that time period. And if they hit some of them, they get some of them. So it moves us into the space of not just paying for the provision of service, but paying for a particular outcome, paying for a particular set of quality steps. So this gets us to my everybody okay? Need to slow down, stop, ask questions? Yes?
The question, are you looking towards measures, the outcome measures moving forward? You know, when we think about this project and the integration of both social determinants and our medical determinants, how are you guys thinking about those social determinants? I was just, thinking recently and reading an article about how across the nation, how does housing such an impact on our outcomes?
Right.
How do we measure that and look for that? Is that some of the plan?
It absolutely is. And the anecdote I'll share with that is that when the IDNs were doing their project planning, they all identified housing as a need and something they needed to address in order to hit their measures. So the social determinants of health that you're talking about, right? Like how do you decrease utilization of X and Y expensive healthcare? Well, maybe stabilized housing would help decrease someone's readmission to the emergency department for a behavioral health issue, right? So they all identified it as a need, but none of them chose a specific project that's focused only on housing, and I think it's because they all recognize that it has to be baked into all of what they're doing, right? It can't be just one, it has to be a component of it. But certainly the social determinants of health are one of the most exciting parts of the district waiver, because we're at that point where, and I should go back, one of the requirements with the networks when we were asking them to build the integrated delivery networks was they had to have multiple community-based organizations, right? Medicaid doesn't pay people who aren't medical providers. I can't pay room and board, right? I don't pay for food security. I don't pay for domestic violence safety planning, right? Medicaid is a health insurance program. But the district dollars, I'm going to pick on my former boss, I can give the district dollars to Nick, and Nick, as the lead of his IDN, can make sure that those services are part of what people receiving services in that network get, so that they are more stable, right? So that maybe they can be moved from a really expensive, intensive way of, or mechanism for receiving medical care into a less expensive. And also the very happy byproduct of getting what they need when they need it, even though it's not necessarily a medical service, it does affect their health and it does affect their health outcomes. So that was, I should have remembered to say that, but it was a unique feature. And we have no capped funding for them. In other states that have similar initiatives, there was capped, the community-based organizations could only receive certain amounts of money, right, to be reimbursed as members in IDN. And we do not have that limitation in our networks. So how they are paid by their network is up to each individual delivery network and what they are paid. But that being said, they are as equal within whatever their governance documents are to receive payment as anybody else. Was there another question? Oh.
In terms of the development of this integrated plan and the creation of the metrics, how have the commercial payers been involved in that conversation, the development of both of those facets?
So it was really an internal discussion, although it was public. We put all of our measures out for public comment and notice. And it was is Dr. Lotz here this morning? Doris, do you want to say anything about, I'm putting you on the spot and I apologize. So we fully vetted it in public. And the woman who is running the district, Kelly Cappuccino, is right down here in the front row. She deserves a big round of applause. She's doing yeoman's work. But we vetted them publicly, but we didn't mirror them and actually Lucy wants to talk about this later. Like, what is Medicaid doing? What are the commercial payers doing? How does it all go together? How do we line all of this up, right? But we certainly used our own expertise to look at what we thought were, and it was hard, reasonable measures, things that could be measured. I remember having very detailed conversations with Dr. Lotz, that just made my head hurt, where she said, well, that's fine, yes, that you want to measure that, but if that only happens once every 1,000 people, and there's only 11,000 people, you can't measure that. And I was like, oh, God, okay. So it's what you measure and how you measure it is a more complicated question than I would like it to have been. That's what I'll say. And one that we continue to work on. It's also an iterative process. We say, okay, we're going to measure that. Well, what data would you need to collect to prove to us that you had, in fact, done that, or that that event had, in fact, occurred? And I have a feeling it's going to be an issue that payers are going to be discussing, hopefully jointly, for a long time in the coming months. Okay, so back to payment reform. So one of the components of my DSRIP waiver is a requirement that we move half of Medicaid provider payments to something called alternative payment models by 2020. So in very, very broad strokes, an alternative payment model is something that isn't fee-for-service, that involves some quality or outcome measure and some risk, right? That's a very broad strokes definition, which sometimes is great that we have that much flexibility, that it is so broad, and sometimes is not great, especially when you're trying to plan. So we have to develop our roadmap to tell CMS how we're going to do this. And these are the roadmap requirements, right? We basically have to tell them how we are going to shift 50% of what we pay to our providers into alternative payment models, and how are we going to embed what is working well in the DSRIP. Sorry, right-hand side, I've been ignoring you. How we're going to build it into whatever our payment model is for our Medicaid delivery system, right? So in other words, right now in New Hampshire Medicaid, that means how do we contract, or how do our contracts with our managed care companies reflect the measures that the IDNs are responsible for, or the mechanisms that the IDNs are using that are successful? How are those going to get baked into those contracts going forward? So we have to talk about what kind of payment approaches we're going to talk about. And we're going to have, as I said, we're going to have to talk about how that payment and our arrangements with providers align with what the IDNs are doing. And it has to be done as per all of our Medicaid requirements, really, with public stakeholder process. So New Hampshire is struggling, I shouldn't say struggling, New Hampshire is grappling with not just the letter of the roadmap, but the spirit behind it. What are we trying to do? How detailed do we want to be? And what are we going to count as a value-based payment model or an alternative payment model as we move forward? So where are we trying to go, right? New Hampshire Medicaid is its nice little world to itself, 13% of the state's population. But is that our goal, to just have alternative payment models that work in that model, or are we trying to help the state move in a larger direction? What are the commercial payers doing? What is Medicare doing? Can we line up any of what we're doing with them so that providers have a few models of alternative payment that they have to follow and the requirements for those? And what are we really going to choose, right? Are we going to allow any number of menu of value-based purchasing models? Are we going to be very, very prescriptive and say you can do these two and only those two and that's it, right? These are not light questions, because as you'll hear later today, not all providers are set up to do all kinds of alternative payment models. Some alternative payment models require internal capacity around data collection, require internal capacity about managing financial risk, right? Sharing clinical and patient information among a broad array of partners, right? And so if you choose the big aggressive super sophisticated alternative payment models as a state, then who are you excluding? Who would not have the wherewithal to which types of providers would not have the wherewithal to participate in that kind of payment model? And what are those providers already participating in that maybe they're already doing for Medicare or that they're doing for their commercial partners? And not everything is going to count as a value-based purchase. I'm not going to read through all this detail for you because this is the bulk of the conversation later today. But these are some of the really hard questions. How prescriptive, right? Who are we going to require to contract with who? And how much flexibility are we going to give our partners? And how are we going to do this, right? What do we need to oversee this? Are we going to actually have the appropriate data and tools to support value-based purchasing? And what do we want to support in terms of payment reform statewide? And are there some services that are of such high value that we don't want them to be in value-based payments? We want them to always be available through all providers, no matter what. Okay. So, yes, Lucy. Oh, Lucy's favorite slide. Because it leads right to the next. Right? When you look at what we pay for, what types of services we pay for, it was right by managed care. There it is. So, this is what I pay for, aside from what is offered to the expansion population, right? This is both fee-for-service and managed care. And the top ticket items are going to be no surprise to anybody in this office. Long-term supports and services for the DD waiver, nursing facility care, right? Top two, easy. Number 3, which is going to be a factor for each and every Medicaid program, actually every payer of health insurance, prescription drugs. And then hospital outpatient and community mental health centers. No surprises. Cindy, yes, or Representative Rosenwald, excuse me.
Do we have data to show that managed care has saved the state money?
Do we have data that shows that managed care has saved the state money? I believe we have tried to look at that, but the analysis for that is a little trickier than I can comment on right now. And I honestly, I couldn't answer whether we have that data or how it would be hard to compare what would the costs have been if we had not been in a managed care delivery system over the last 4 years. Dr. Harker.
So I asked about the distribution of the spend earlier, and as we're thinking about value-based purchasing, in the world that I work with some of the commercial payers, we try to say, what are opportunities within segments to have decreased utilization? So we might look at ambulatory care sensitive conditions. If we take that thinking to your graph there with the spend, and that graph and that table up there now, has anyone done a sub-segment analysis to see if, on your long-term services expenditures, would value-based purchasing have an impact on that? Or is it going to help more people who are relatively well using the emergency room inappropriately? Because value-based purchasing isn't going to be a magic wand that fixes everything.
Correct. Right, exactly. And I don't think we have that level of analysis, but Joe does have some excellent data that is more detailed than what I have on what conditions we are paying for and where that care is being provided that we are paying for. This is just the initial part of this conversation. This must be a data-driven conversation, and it requires endlessly more data analysis than I ever anticipated. Although I welcome it. I'm happy to know what the information is so that we can make smart choices moving forward. But I don't have that here today, but I think Joe's presentation coming up quickly will be an excellent second part of that conversation because we have to start somewhere, right? And so starting with the facts first is always good. Dr. Kraft?
Thank you. Is there a commitment in addition to designing the alternative payment model, to take the shared savings and to invest those in those social determinants of health that will help us with the upstream causes of these large costs?
So I think that is really what is behind the move to alternative payment models. It's not an in writing promise or guarantee or commitment, but I think the shared savings model makes total sense, right? That if you manage to efficiently manage your program, that you have the wherewithal to funnel it back in to the places that really make sense for your beneficiaries. I know Cindy is going to talk later in the afternoon about the AHCA, and the reason I bring that up is the idea of operating under a per capita cap system, as is currently laid out, sort of brings to mind the idea of, okay, if I hit my target, do I get a shared savings for being efficient that I can then funnel back into my program? For New Hampshire Medicaid, it would have to happen within the district because, again, Medicaid can't reimburse for those types of services. But the general funds that were matched, that can be used for the district, right, allow us that flexibility. And then hopefully we have proof of concept so that we can say after a certain number of years, this really worked, we should be paying for this because the return on investment is excellent. And as you know, right, we're hoping that our IDN partners are the ones who help us identify which one of those mechanisms are the ones that are really going to pay off for us. Nancy, yes.
Thanks, Deb. So,
Can I just say, if you can identify yourself when you ask the question? that would
Nancy
be
Rollins,
terrific.
I'm the Chief Operating Officer with Easter Seals. My question has to do with the current array of Medicaid services, if you will.
Yeah.
And whether or not there will be an opportunity to sort of examine whether or not those services we currently have are meeting the needs of certain subpopulations. An example being people with acquired brain injury. Research has demonstrated that the more that you front load services after a traumatic event or whatever, the more likely the person will rehabilitate and do better. We have a tendency through our waiver to sort of backdoor that relative to how we provide services. And our current state plan doesn't provide sufficient occupational therapy, physical therapy, and so forth to truly front load that. So I'm just wondering if there's an opportunity, and it's costing us more money in the waiver program.
So I think there's always that opportunity, and if there is evidence that we can rely on to say we should rearrange it in this particular way, I invite you to, we can, please come meet, let's talk, let's see what you're seeing. Because yes, I think all Medicaid programs are looking for any efficiencies that they can find, absolutely. Yes?
I'm Ed Shamsham, the CEO of Amity Community Health Services and Board Director of ACO. And I just wanted to back out to 30,000 feet. And one of the things I like working in New Hampshire, I lived in Pennsylvania, I worked in New York, is the ability to get colleagues like this together across all payers and all disciplines. And the access to the state is actually exceptional in my experience. And the collegiality is really quite exceptional. What I look at is the opportunity, similar when CHI, the Citizens Health Initiative, got people together to work on patient-centered medical home. We had a lot of payers in the room. A little nervous because we have a lot of payers in the room. There's certain things that they can't talk about. It makes them nervous, and that's okay. Is that when we see patients across the continuum of their lifespan, and with the ACO, we see them across the continuum of care. The opportunity is on the data set to get to the minimum, essential, meaningful, actionable data set. It's very frustrating to see multiple payers have multiple metrics, and it drives up non-value added costs at a time we're expected to add value. So that's an opportunity, I think, to have those people come together as stakeholders. And when I think about value-based purchasing, whose values? Patients, the providers, the industry, whose values are we talking about that we're driving from? And can we get to a common platform? Because again, my billing department would appreciate, they would smile if we could get together. We're a small enough state, I think, among CMS and Medicaid and the payers, we could come up with a reasonable modality. And the last thing I worry about is shared savings, not an infinite regression.
Right.
So I'll leave it at, I think we have the right people in the state to actually do something quite novel.
I agree, and Medicaid is very aware of creating yet another set of hoops for providers to jump through that are divergent from what they're already doing for, I mean, you know, the big heavy is Medicare, right? And then commercial and then Medicaid, right? And so is there a way to, as you said, I mean, we're very aware of that, align that in a way so that providers don't have to do 12 different sets of unique and innovative things in order to help us move towards sustainability of our healthcare system.
And the state has been responsible for primary care contracts. There's been tighter and tighter alignment to minimum essential meaningful elements of action.
And I know Lucy will want to, and her panel will want to talk about that.
Were there other questions over here? Did I see? Yes, Mike.
I have a question about the rates of pay.
Yes.
So in your formula, do you consider the changing rates in pay? For instance, pharmaceutical costs continue to rise at higher rates, but other costs, let's say payment for people at community mental health centers, has remained pretty flat for a long time. So how do you adjust for where you want services to be provided? Do you want them all to go into the rising cost of prescription drugs, or do you want them to go to paying for people to deliver services in community?
Well, I think we do one better. We go for paying for particular outcomes with the particular quality metrics, right? So that we say we want this kind of care because this is high value care, right? And we want the person to have a very positive experience, and we leave it up to the providers to work out where the circle of dollars go, right? So I think that's really where alternative payment models is going, is to take us out of the individual bean counting and rather say, this is what we're shooting for. I'm going to pay you to go there. You work it out, right? Okay, so I've been told I'm getting the hook. Thank you so much for coming and wanting to talk about Medicaid. It is my great pleasure to serve Medicaid, and I'm happy to be with you today as we talk about these really interesting and thorny things. Thank you. All right. So thanks to Deb. I hope we all feel a little bit more sort of grounded in the background of Medicaid. I know I do. I learn something every time I hear one of these.